Hello, my name is Eric and I am a student nurse at the University of Michigan in the Second Career Program. I have been assigned to Unit 6B of UMHS for my clinical assignment, and I am here today to present a patient to you. A 41-year-old single obese Caucasian female who is a former RN but has not worked in over 10 years presented to the UMHS ED on November 6, 2014 with severe lower back pain in excess of her chronic back pain. She was in her usual state of health until about 8 weeks ago when she began to experience indolent worsening of her chronic lower back pain. The pain radiated downward and bilaterally into her buttocks and toward the knees. The pain worsens with activity, wakes her from sleep at nighttime, and has been associated with increasing frequency of body aches. She has rated the pain as 9 out of 10 as compared to her normal 5 to 6 out of 10 range, which is severely limiting her ability to carry out her ADLs. Patient noted she tried to continue functioning with her current pain management regimen for her rheumatoid arthritis, but the pain has become unmanageable. She notes her body temps have been in the 98.5 to 99.5 degree Fahrenheit range, which is an elevation compared to her normal baseline of 96 degrees Fahrenheit. Notably, she was admitted for the same problem in September 2014, at which point an MRI was performed that showed an abnormality at the L4 and L5 level consistent with degenerative joint disease. She was seen by neurosurgery and rheumatology in the interim. Her erythrocyte sedimentation rate test was repeated and found to be elevated. The ESR test is used to help detect inflammation associated with conditions such as infections, cancers, and autoimmune diseases. Because the patient is preparing to undergo treatment of her RA with methotrexate, an immunosuppressive drug, it is important to rule out infection, cancer, or some other disease that would become opportunistic in the presence of a diminished immune system and that would contraindicate methotrexate therapy. It was recommended that she be admitted for a biopsy of the L4, L5 area of the spine and further investigation of possible lumbar spondylodiscitis, an infection usually by Staphylococci and Mycobacterium tuberculosis involving the intervertebral disc and adjacent vertebrae. She was subsequently transferred from the ED and admitted to Unit 6B of UMHS. Her vital signs are stable, blood pressure is 136 over 74, heart rate is 85, respirations are 20, temperature is 98.1 taken orally, and her oxygen saturation is 92% on 3 liters of oxygen through a nasal cannula with a humidifying device in place. The patient was previously admitted to UMHS twice in the last 12 months. In early 2014, she was admitted for cellulitis, and the condition has resolved itself since that time. The patient was also admitted to UMHS on September 14, 2014 for lower back pain. At that time, the condition was diagnosed as degenerative joint disease, and she was discharged and told to continue her current pharmacological pain management therapies and to notify her healthcare professional of any worsening of conditions. Since that time, the condition has worsened, hence she is seeking further medical attention with this admission. The patient notes nothing of significance regarding past surgical history other than having her tonsils out as a child. However, her past medical history is quite extensive. As a child, she notes having chickenpox, but no other childhood diseases of significance. The patient also presents the following comorbidities and health problems: type 2 diabetes, RA, osteoarthritis, degenerative joint disease of the spine, asthma, hypertension, Sjogren's disease, migraines, obesity, depression, anxiety, ADD, peripheral neuropathy, erosion of the nasal septum, esophageal dysmotility, sterile autoimmune wounds, benzodiazepine and narcotic dependence, and chronic steroid use. All immunizations and vaccinations are up to date. Most recently, she received a pneumonia vaccination on October 1st, 2014, and a flu vaccination on October 20th, 2014. Her only known allergies are drug allergies. She has an allergic reaction to compazine resulting in a rash and an allergic reaction to Avelox, which results in a rash, diarrhea, and nausea. The patient takes numerous medications for her various health issues. Of particular note, though, she takes Bumex for hypertension and edema, Cymbalta for depression, Ativan for anxiety, insulin and Novolog 70-30 mix for her diabetes, oxycodone for pain management, morphine for breakthrough pain, and sulfasalazine for her RA. A functional assessment revealed that the patient denies alcohol use, however, drinks numerous caffeinated diet pops throughout the day. During her hospital stay, the patient is on a consistent carbohydrate diabetic diet consisting of 2,000 calories and 75 grams of carbohydrate. She indicates that she normally does not eat healthy and eats a high carbohydrate, high fat diet at home. She denies illicit drug use, but accepts that she does have physical and psychological dependencies on prescription benzodiazepines and opiates. Patient notes she was a smoker for 4 years, but quit a few years ago. She has no exercise regimen other than physical therapy sessions that consist of mainly stretching. Patient states she has poor quality of sleep and suffers from insomnia. Pain, depression, and anxiety are all factors that affect her quality of sleep. It makes it hard for her to fall asleep, and when she does, it eventually wakes her up. She also verbalized that she thinks she may have sleep apnea and has an appointment scheduled with a pulmonologist in 2 weeks for a sleep study. A psychosocial assessment showed the patient to be single, never married, and not having any children. Her parents are both alive and still married. She has resided with them for the last 10 years, and they have become her primary caretakers. She indicates that they are highly supportive of her. Patient also has multiple brothers and sisters still living who live outside the household, and she has communicated that they are a strong support mechanism for her also. She states that because of her condition, she is mostly confined to the house. Her time is mostly spent with her computer, on social network sites, or watching TV. She wishes things were different. She communicated that she has low self-esteem because of her health issues, primarily with her obesity. Patient accepts that these issues are contributory factors to her diagnosed depression. However, she is highly involved in her Catholic faith, and she notes that through prayer, relying on God and the support of her family, she is able to cope with all of her issues. A review of her family history showed nothing of significance. Both sets of grandparents are still alive, as well as her parents and all of her brothers and sisters. She states they are all in good health and jokingly explains that this is the case because she got all the health problems. High priority system number 1 is the musculoskeletal system due to the several comorbid issues of rheumatoid arthritis, osteoarthritis, and degenerative joint disease of the spine. The rheumatoid arthritis and osteoarthritis result in a high pain level and stiffness of all her joints. Her pain is chronic and ranges in the 6 to 9 out of 10 range. Her pain medications help keep her at a 6 out of 10 level, at which it is tolerable, and she is still functional. When pain goes above 6, she rapidly loses her functionality. The pain and stiffness lasts throughout the day. Her back pain is a result of degenerative joint disease. Range of motion is limited in all joints due to pain and stiffness. Patient can move upper extremities and lower extremities without assistance, but range of motion and strength are limited against gravity with moderate resistance. Hand grasps are equal but weak. Dorsiflexion and plantar flexion of the ankles are limited against moderate resistance due to pain and stiffness. Her back pain and stiffness, for the most part, have confined her to a sitting or lying position. Patient's current pain condition severely limited the ability to do a comprehensive musculoskeletal physical exam. She does deny any history of broken bones, paralysis, or tremors. Patient needs assistance with most ADLs. She needs assistance ambulating to the bathroom for toileting and bathing, and depending on the severity of her pain and stiffness, she at times needs assistance with these activities. She also at times needs assistance with dressing when the pain and stiffness are severe. She is, however, independent with feeding, but does need someone around in case of choking because of her esophageal dysmotility. Activity tolerance is limited due to pain and stiffness complicated by asthma. She becomes short of breath upon exertion. She does participate in physical therapy, mainly stretching, but she says it's hard to tell if it's helping because her back pain may be covering up the progress. Patient does use a walker to assist with ambulating, however, standby assistance is still necessary. She also uses a shower chair when she bathes. Patient is a fall risk due to range of motion limitations, pain and stiffness in her joints, sensory impairment from her peripheral neuropathy, and high usage of benzodiazepines and opioids. Patient also experiences chronic fatigue from her RA. High priority system number 2 is the respiratory system. Normal or abnormal chest configuration was hard to determine upon inspection because of the patient's obesity. Patient presents effortless breathing and only labors upon exertion. However, she does present a diminished respiratory pattern at times. Upon palpation of the posterior thorax, no pain or crepitus was observed. Auscultation of the anterior, posterior, and lateral aspects of her thorax revealed diminished sounds in all quadrants. Her high opioid use may play a role in this. No crackles or rhonchi were present. However, slight wheezes were present, attributable to her asthmatic condition. Patient denies cough. Oxygen saturation levels range between 92 and 97% on the intermittent pulse ox. Vitals are assessed every 8 hours. Patient is on supplemental oxygen at 3 liters through a nasal cannula in the hospital and at home. A humidifying device is in place. 5+ years of supplemental oxygen through a nasal cannula has caused erosion of the nasal septum. Patient uses Q-tips to maintain patency when blood or mucus is present. Patient verbalizes using an incentive spirometer sporadically and sparingly. She experiences shortness of breath upon exertion and has asthma, which also contributes to her shortness of breath. Patient uses albuterol and Advair to control her asthmatic episodes. Patient also notes that her asthma does restrict her ADL to the point assistance is needed. Patient also experiences occasional pleuritic pain due to Sjogren's disease, which can cause discomfort when breathing. It should be noted that the patient uses high doses of opioids, which suppress the respiratory system. Therefore, frequent monitoring and assessment of this system should be in place. Pertinent system number 1 is the gastrointestinal system. The patient has been managing her chronic pain from rheumatoid arthritis, osteoarthritis, and degenerative joint disease with long-term and high-dose use of opioids. It is important to assess the gastrointestinal system because of opioid-induced constipation. According to an article in the American Journal of Gastroenterology, there has been an alarming increase in the prescription of opiates and opioids for chronic non-cancer pain in the past 15 years. It is estimated that opioid-induced constipation is experienced by greater than 40% of these patients, and that constipation and other gastrointestinal symptoms may dissuade patients from using the required analgesic dose to achieve effective pain relief. There should be a greater emphasis placed on nursing interventions and treatment for constipation in patients utilizing long-term opioid therapy for chronic pain so that they continue their pain management regimen and not discontinue its use because of unwanted side effects such as constipation, thus putting themselves in a position to experience the undue hardship of pain. Pertinent system number 2 is the cardiovascular system. It is important to assess the cardiovascular system in this patient because of her chronic illness, rheumatoid arthritis, which affects the musculoskeletal system and also affects the cardiovascular system. According to an article in the American Heart Journal, patients with RA have a 1.5 to 2-fold increase of developing coronary artery disease compared with the general population, and at diagnosis, individuals with RA were over 3 times as likely to have a prior myocardial infarction than subjects without RA. This point, along with the fact that the patient also has hypertension, another risk factor for coronary artery disease, makes assessing the cardiovascular system a vital part of this patient's assessment.